Start recording. Okay. Okay, there we go. Okay, so acute glomerulonephritis is an allergic reaction to an infection. So now the person has had an infection and their body's kind of in hyperdrive and ends up causing this allergic reaction that causes the glomerulus to be all inflamed, all those little capillaries. Group A, beta hemolytic streptococcal infection. So basically strep. Strep throat and strep upper respiratory infections are largely the cause most of the time. Impetigo, which is a skin infection. After they've had that, a lot of wrestlers get impetigo from mats that haven't been cleaned well. And after that skin infection, they're at risk of getting this also. They have, in the literature, post-staph infections are on the rise. So before it was pretty exclusively strep, but now that we're seeing more and more and more staph infections, and we're seeing some of these glomerulonephritis, I can't say it very well, but after post-staph infections. Bacterial endocarditis, so they have, you remember when we talked about with our Peds heart stuff, and they've got infection in the endocardium, and some of that vegetation can break off and go systemic. Well, they don't know the exact, in the literature, they don't know the exact correlation, but they are finding that people who have had bacterial endocarditis are also ending up with acute glomerulonephritis. It might be an autoimmune response where the antibodies settle in the glomeruli causing inflammation. So you have all these antibodies and they're sort of getting stuck in the kidneys and gumming everything up. It's more common in kids, 5 to 15 years old. It isn't really clear why. That just seems to be the population where they see it the highest. There's a history of infections, viral or bacterial, and there's a decreased glomerular filtration rate, your GFR. So greater than 90 is a healthy kidney. So you're filtering greater than 90 mils a minute of blood, and less than 15 is complete kidney failure. So it'll be less than 90, but it's going to be greater than 15. Does that make sense? You're not filtering as well. Your GFR will go down. Clinical manifestations, it's a pretty abrupt onset. Symptoms can develop as early as 1 week after the infection. If they have a strep infection, sometimes they're still on antibiotics, right? Because they have like a 7 to 10 day course of antibiotics. And then all of a sudden they start having kidney problems, edema, hypertension, some issues like that set in before they're even done with their antibiotics. Other ones like impetigo, sometimes they've been over that for 2 or 3 or 4 weeks, and then this sets in. Proteinuria can be mild to moderate, so they're spilling some protein, but when you come down to here, this is going to be our biggest concern. With the proteinuria, it causes foamy urine. That protein that's in there will cause this frothy or foamy urine, and a low intravascular protein. So proteins and electrolytes kind of have the osmotic holding pressure to keep the fluid in the vasculature. If you don't have enough protein, it'll start to leak out into the tissue. But with these guys, the main problem with their edema is that they have inflammation in the glomerulus, and that's right before the renal tubules. And so their sodium reabsorption, it's not making it all the way through because the problem is in that bed of capillaries. So they're holding on to the sodium. And what loves sodium? Water, right? And so it's a sodium water issue. So then we're going to have some other issues with blood pressure and stuff. Hematuria. So the damage to the basement membrane that's in the kidneys is such that it leaks red blood cells profoundly. So you will have gross hematuria. It'll be dark red. Usually it's a little bit older blood, or tea or cola colored. So it looks more than just concentrated. It looks like really brown. And you might be able to see some red in it, but it really looks really dark. So remember that with this one, that's where you're spilling the most is red blood cells. So even though they lose a little bit of protein, the majority is this. Then they'll have edema, facial and periorbital. So like this little guy over here. The protein and electrolytes kind of exert that osmotic pressure. And if you're losing some of those proteins, then you won't have as much holding power in those vessels. So they will have marked hypertension. This is a salt and water issue. And so they're not excreting what they need to, and they're holding on to too much sodium. So that water stays with it. Moderate to severe, secondary to fluid retention. This one is pretty unique of this kidney problem with the marked hypertension, and they will end up needing, most of the time, will need antihypertensives. Oliguria, scanty urine output. So if your kidneys, if your glomerular filtration rate, oh my gosh, that's so hard for me to say, is lower, you're not filtering through as fast, right? And so you're not going to have, plus you're holding all this fluid out in the tissue, you're not going to have much urine output. So remember that you're not going to have, tons of urine out. And what little bit you have is going to look really dark, kind of cola colored. Fever, they'll have a low-grade fever. This azotemia is nitrogenous waste in the blood. So it comes from protein metabolism. That causes a buildup of urea, which can also cause dry, itchy skin. So when you have that buildup of the protein metabolism, you have this nitrogen in there, and it causes what they call azotemia. In the renal function tests, your BUN and creatinine are elevated, right? When kidneys aren't working well, BUN and creatinine go up. BUN also goes up when they're a little bit dehydrated, right? And we're holding all this fluid out in the tissue, and kidneys are reabsorbing, are holding on to the salt. We're not moving everything through the vasculature, so they actually can present a little bit dehydrated, even though they're edematous. They might have dry mucous membranes. They won't have sunken eyes because they'll be all puffy, that periorbital edema. So you'll have to kind of rely on your mucous membranes. But would you want to give them fluid? No, because kidneys aren't functioning, right? They're not moving the fluid through like they should. They're holding on too much salt, and we're going to end up elevating that blood pressure even more. Okay, so we don't want to give them fluids right now, but we do want to watch hydration status by watching their mucous membranes. Or if they're a little tiny one, then you can look at their fontanelles. So sometimes they'll get like an ear infection, upper respiratory infection, and then it's migratory, and they end up having the acute glomerulonephritis, and they're just little. So most of the time you've got school-age kids, a little bit older, but I have seen it in kids that are young enough where you can fill their fontanelle. So 18 months-ish. And then your GFR will be decreased. So these two increased, GFR decreased.
I have a question.
Yeah.
So, I know you wouldn't give them fluids, so would you give them, I can't think of the word, but the fluids that have a lot of stuff in it to suck some of the, does that make sense? What am I trying to say?
Fluids that have
that isn't, yeah, I can't remember what the word is I'm looking for, but like D5W or something like that,
where you've got
stuff out of that interstitial space. Would you want to give that to them?
So
no?
Giving them a diuretic will help pull that out of the tissue into the vasculature, and they'll be able to get rid of that. But you wouldn't want to give them anything that has sodium in it, because then you're going to you'll exacerbate the problem. And potassium, we're going to talk about here in a minute too. When kidneys aren't functioning well, they don't filter out potassium. And so your potassium will end up being elevated. And so really the only problem would be your D5. And if they're POing a little bit, they're usually going to maintain a blood sugar. So you really have to watch and be judicious with your fluids. Weigh your pros and cons. If they're really, really dry, then yeah, you need to be giving them a diuretic, but maybe a tiny bit of D5 to maintain a blood sugar if they're not eating.
Okay.
Yeah. Did that answer your question? Okay.
Kind of once I can figure out how to word it, maybe I'll.
Okay, then ask again, please.
I can't think of it.
Oh, okay, yeah. Then ask again. Okay. They'll be very lethargic. because they're anemic. They're losing all those red blood cells. They'll have abdominal pain related to the uremia, lots of nausea and vomiting. So that can exacerbate the dehydration, even though they look edematous, right? So it's a little bit of an oxymoron. Usually we think we see sunken eyes and this really dry little kid, but now they're edematous and it can almost fool you. So look at all of your assessment pieces. They will have a headache, usually from the elevated blood pressure, from the hypertension. Crossover T-roll flank tenderness, so that's that CVA, that angle that's right here. So if you tap on it, I guess I should show the camera, right? Right there. If you tap on it, it really is quite painful. So whenever you are wondering about kidney problems, just a gentle tap is plenty. Because they will, don't do that. Pulmonary edema related to the fluid overload. So if they're having some pulmonary edema, what might your assessment be? Hackles?
Shortness of breath.
Shortness of breath. Yeah, so the rhonchi is going to be a little bit more mucousy. This is just fluid. So it'll be kind of crackly. They'll have some shortness of breath. They might have some oxygen needs because of that pulmonary edema. It's mostly a short-term illness, which is nice because it comes on pretty quick and then it goes away pretty quick. It's pretty self-limiting. A few weeks to months, so usually within about a week, things start to resolve. And by about 3 or 4 months, gone. And about 95% have a complete recovery without continued kidney issues. And with it being self-limiting, it doesn't come back, like it doesn't reoccur. It just, once it's gone, it's gone. All right, with a urine sample, with your diagnostics, you're going to look for some protein in the urine. Red blood cells, they are dysmorphic. What does that mean? Misshapen, yes. And then the red cell casts. So these are the body's trying to kick out more red blood cells, right? Because we're losing them. And so, so you will see the red cell casts. And then you will have over here with the, I didn't put it, but that's where you'll have the cola-colored urine too in your UA. But you will see these things. In your blood test, you will see an increased BUN and creatinine, a decreased GFR, and then your antibody titers. It will show if you draw a titer that there is a strep titer that's usually higher because we now have just completed having a strep infection or staph, whichever. They can draw a titer on that. And then a kidney biopsy isn't always performed because in about a week, things start to resolve. And a kidney biopsy has a fair amount of risks with it. It's a very vascular organ. So if you go in and take a biopsy, then you risk having bleeding, which can further have other issues. So unless it's a really unclear case and they can't link it to anything, then they might go ahead and do a kidney biopsy. So your interventions, they're largely symptomatic and supportive because you're not going to just make it go away. It's got to kind of run its course. Medications, diuretics for sure, right? We've got to pull that fluid into the vasculature so we can get rid of it. Antihypertensive medication. So this, with the calcium channel blockers, they often use those, but not ACE inhibitors. Does anybody have just a guess on why ACE inhibitor? What can they elevate? What electrolyte? Potassium. They can elevate potassium. And if your kidneys aren't functioning well, they don't filter out potassium very well. It's a larger molecule. It's more difficult to get rid of. And so we don't want to give ACE inhibitors and perpetuate that problem. And then antibiotics are needed only if we're still treating the infection. So if this set in at a week and we still have 3 or 4 more days on our antibiotic to kill that strep infection, it will continue the antibiotic. But it will not cure this immune response for the kidneys. Does that make sense? So we wouldn't give them an antibiotic if they were already done because it won't help. It won't do anything with this. This isn't an immune response. Diet will restrict sodium, restrict fluids, and potassium, and often protein. With acute kidney injuries, protein is also kind of difficult to break down, but they're not losing a ton of protein. They're just losing a little bit. So that isn't a big problem for us. And this doesn't last real long. And so about the time we really start to get to see really low protein levels, this is pretty much over. It has run its course. Strict I's and O's. And so you really want that relationship. Okay, so not just output. You need to have your intake also.
Would you say then moderate protein?
Moderate protein, well, they often limit it with this one, but with the next one, the nephrotic syndrome, they do want moderate protein because we're losing so much protein. So this one, we're losing a ton of red blood cells. But in the next one, we're losing a ton of protein. So yeah, so this one, we would often limit it because it's a short-term issue. The next one goes a little bit longer. So that's a good question. Let's see, assess for edema in the skin, lungs, and periphery. If you have a lot of edema in the skin, what's your risk? No? Breakdown, yeah. Because it's so edematous that it's thin, right? It can tear easily. And so you really need to position them pretty often. Your Q2 turns, get them off that edematous tissue and be able to kind of give it a break. Monitor your vital signs frequently, particularly the blood pressure, because it can get pretty high. And kids don't have high blood pressure, right? And so we really need to pay good attention to their blood pressure and make sure that those antihypertensives are working. Frequent skin assessments, if they're edematous, prevent the spread of infection. So they've recently had a strep infection. We might still be treating it. So we definitely need to have them on precautions and be washing our hands. The immune system is really taxed because of the previous infection. So they've been fighting this strep infection or fighting this staph infection. And then now they've got this immune response and the body is like shifting gears and it's working really hard to kind of rein this in, I guess would be a good way to say it. And so they really can be at risk for having other problems and other infections. So when we put them on precautions, it actually helps keep them from getting something also. They're already fighting the other infections. That makes sense?
So you're doing reverse precautions?
You would do just your normal regular precautions because you don't want to transfer anything to you or to other people. But the nice side effect of that, I guess, inadvertently, is that it will help you not bring something back to them too. So you wouldn't initially call it reverse precautions.
Okay.
You are trying to prevent the spread of infection.
Okay, and this is like contact precautions.
Uh-huh.
Okay.
Yeah. Contact precautions. Sometimes I forget to re-say what you guys say so they can hear it online. So remind me. Dialysis is unusual unless there's a lot of fluid overload. Hyperkalemia, usually over like 6.5, and they'll go ahead and dialyze them. Elevated BUN, like 80. That's really high. It's like 7 to 20 is what your BUN usually is. And so if it's up near 80, then they'll go ahead and do dialysis. One cool thing with the hyperkalemia is albuterol binds to potassium. And so they can give them breathing treatment, which isn't going to hurt anything, right? It might speed up their heart rate for a little bit, get a little bit tachypnic, tachycardic, might feel a little anxious, but then that potassium comes down because it's binding with that albuterol. Kind of cool. I had just heard about that right prior to giving this lecture, but wasn't really sure what the relationship was, and then had a respiratory therapist in that class. And she said, oh yeah, we give it to patients that have a high potassium. We just go in and do a breathing treatment. Do a couple of them over a day or two, and it helps bind that potassium. So, not something you would normally think, right? Nice side effect of albuterol. Okay, any questions on acute glomerulonephritis? Any questions? Make sure that I keep them included. Nephrotic syndrome refers to a syndrome, not a specific disease. So it has all of these pieces to it. It'll have edema. Now the other one was characterized a lot by the blood pressure. It was very high, the tea or cola colored urine. Now this one has edema, but it can have profound edema because we're losing protein. So the damage to the basement membrane in the kidneys was such that we were losing largely red blood cells in the first one. This one, the way the damage has happened is we're losing a lot of the protein. So massive proteinuria, 4+ you will see in the urine, which is a lot. Hypoproteinemia, particularly your albumin. Albumin is like monster holder of oncotic pressure into the vessels. So when you get hypoalbuminemia, then you really have a hard time holding any tissue or holding any fluid in the vasculature. And so you will really have a profound amount of edema. Because that albumin is low and you have a low oncotic pressure, then the liver starts to go, oh, wait, we need some more protein. But it kicks out lipoproteins, which helps some, but then it elevates what? Lipoproteins will elevate cholesterol and triglycerides. Yeah. So you will see those go up. So because of the low protein, low oncotic pressure, now we have the liver kicking in and doing the lipoproteins. It will also have an altered immunity because they're losing gamma globulins. So hypogammaglobulinemia. And so your IgG. And it will alter their immunity. They will not be able to fight off infections very well. They lose quite a bit of those gamma globulins. So all of these things together make up nephrotic syndrome. So a little bit of the patho. Primarily, it results from a disease affecting only the kidneys. So this isn't an immune response. This is a disease that is affecting the kidneys. If it's secondary, it's a systemic disease from drugs or toxins that have now altered the kidney function. Okay, so we either have something that is a disease that's attacking the kidneys or something else that was systemic that now is having secondary kidney issues. Or it can be congenital, an inherited genetic defect, and that'll bring us down to this, so I'll get there in just one sec. It increases the glomerular basement membrane permeability. So what that means is it's more permeable, it's more, not transparent, it's more permeable. What's another word for permeable? Leaky. It's kind of leaky and it leaks protein through there. That's a very technical term. Please make sure that's in your notes. But that's exactly what it is, and it just kind of lets the protein fall through into the urine. What's that?
There's leaky potassium channels.
That's true. Then you can have, leaky potassium channels. You can have leaky basement membranes. This minimal change nephrotic syndrome or disease is MCNS or MCD. And basically, it's idiopathic. So if you read anything about nephrotic syndrome and you see that largely it's idiopathic, it just happens to some kids, and it's often. They can't link it to something else that has happened. It just has happened. And that is more treatable than something else that might be like a disease that has affected the kidneys and caused an acute kidney injury. Most common, 85 to 90% of cases, is this minimal change. So that's kind of nice because then more kids will get better from it as opposed to having an acute kidney injury that is lasting. And so it ends up becoming chronic. So clinical manifestations, it's generalized edema that develops over several weeks, so it's more insidious. So your acute glomerulonephritis comes on like that. We might still be fighting an infection, now we have this immune response. The nephrotic syndrome kind of sneaks up on you. And parents will come in and be like, you ask them about edema. Well, I kind of noticed when they wake up from their nap, The side they were laying on is kind of swollen. So you've got that dependent edema. Or I took their sandals off and their little feet look kind of swollen. And they start really kind of paying attention going, oh yeah, they just kind of look kind of puffy. But haven't really noticed the change because it's kind of slow. They can have marked peripheral edema. Once this really takes hold, it starts out periorbital at first, but then once they really start having problems with it, it can become generalized. So that's the anasarca, generalized edema, and they can even have ascites in severe cases. And I've seen little kids with big bellies because they have a lot of ascites from this. And it's because of that massive protein loss that we have. We can't hold that fluid in the vasculature very well. And so now we are having a lot of issues with edema. So they will have weight gain. Hypertension and hematuria are less common because it's not a salt and water issue, it's a protein issue. Okay? And so when you have salt and water, then that will drive that blood pressure higher. And if you're just losing protein, and that's causing the edema in the tissue. They lose more protein than red blood cells. So you might see a little bit of blood here and there, but it's really not profound. And then frothy or foamy urine, so because of all that protein, right? So it'll be even foamier, or more foamy, I guess, than the first one. And it will also have oliguria. And I have it in black because you guys always, I don't know what the heck you guys think sometimes when you're like, oh yeah, they have great urine output. No, they don't. They're holding it all in the tissue. And they're not having enough fluid that's going through the renal tubules to be reabsorbed or let go because it's all sitting in the tissue. So very poor urine output. And then they can be very tachycardic. Why do you think they're tachycardic? Okay, blood pressure, and they're compensating a little bit. Why is our blood pressure, let me think of this. How do I ask this? Why isn't the blood pressure very high?
Because you have no protein to hold that in.
Right, so you don't have enough protein to hold fluid in the vasculature, right? So we're technically hypovolemic, even though we're very edematous. And so that blood pressure won't be hypertensive, it can actually be kind of low. And so that tachycardia is the compensatory piece of that. Does that make sense? Yeah, good job. All right, clinical manifestations, lethargy, malaise, irritability, they feel really crummy, really, really crummy. They can be very pale. They can have pleural effusions that'll cause a lot of dyspnea. So you've got that fluid that's just kind of taking over all kinds of tissue and all kinds of spaces, and they can end up with a pleural effusion that makes it very difficult to breathe. They'll have intestinal mucosal edema that causes diarrhea. They don't feel good. They have nausea and vomiting from that urea that's building up, and no appetite. They're susceptible to infections because of the loss of the immune globulins. And this one has remissions and recurrences. So the first one's limiting, right? It's self-limiting. Gets done, it's over. 95% of kids move on and they don't have problems. But this one has remissions and recurrences, so they can get better. And then they start to have trouble again, and they start swelling, and they start having more issues with their kidneys. And then they get better again, and then they can have another reoccurrence. And so you kind of see this ebb and flow. Sometimes it lasts for years, and other times just a couple of months. Maybe you'll have one remission and one recurrence, and then a remission again. Okay, just remember that it can come and go. So with your labs, 4+ protein in the urine, the proteinuria, increased specific gravity. So tell me about this. Increased specific gravity.
Dehydration.
Can be dehydration. And so we've got a lot of solute there, right? And we're not filtering out a large volume. Our glomerular filtration rate goes down. And so our specific gravity can go up. An increase in creatinine. We'll also have an increase in BUN, I don't see how I put that on there. But those two will travel together here because we're talking kidney injury. What's that?
Oh, I said 1.3 kidney injury.
1.3 kidney injury? Tell me what you mean.
It's just, she's quoting Nurse Mike. Yeah.
Oh, okay. I was like, was that something that I said? And I can't. And now I'm having a hard time remembering.
No, you're just
Decreased GFR and hypoalbuminemia, hyponatremia, and hyperkalemia. So hyponatremia, we don't have a lot of sodium. This isn't a sodium and water issue, but we're holding on to all this extra fluid, which will kind of dilute that sodium, right? And so it can look a little bit low, but our kidneys are not getting rid of potassium. They can be hyperkalemic. Hyperlipidemia from those lipoproteins from the liver, and the serum cholesterol and triglycerides will be elevated too because of those. So you've got your labs going every which way. Yes. Did somebody start just listening?
No, I was kind of curious. So with this one, you have hyponatremia but hyperkalemia. And the other one, you're saying that you have. I can't remember.
You'll be holding on to the salt and water because where the damage in the capillaries is taking the glomerulus, and the damage in the capillaries is before the renal tubules. So before it's going to reabsorb so it can excrete the urine. So you have that damage, so it's going to hold on to the salt and the water, drive that blood pressure up, cause some edema. Is that what you're asking right there, that relationship? So the sodium, if you were to look at labs for acute glomerulonephritis, you might see hypernatremia.
I was just wondering if, like, because you're saying that you would use calcium channel blockers but not ACE inhibitors because you don't want to increase potassium.
Uh-huh.
Never mind. I got confused that way.
Oh, okay.
Go ahead.
Okay.
I confused myself.
Okay. If it comes back around and you have a question, let me know.
Okay.
So they can be hospitalized initially and then be outpatient. So initially they're very, very sick, but as they start to go into remission, and sometimes they can be treated on an outpatient basis. So medication, corticosteroids. This is a pretty interesting relationship with diuresis. So when you don't have a salt and water problem for that's necessarily your edema issue, then diuretics aren't always going to be very effective. But corticosteroids can cause them to have, it decreases their immune response. So when and decreases inflammation. And so they don't fight it off as well, and they're more, okay, try again. Sometimes it's hard to put into words. So you're going to decrease your inflammation with your corticosteroids and in your basement membrane. So you're going to have less injury, less inflammation. You're going to excrete fewer proteins. Then, so that will cause them to be able to diurese because now you've got more oncotic pressure in there, more holding power, right? So then the fluid can stay in the vasculature long enough to go through the kidneys and be excreted. I better way to say that. Diuretics only for respiratory compromise. So if they have a pleural effusion or they're holding enough fluid in their lungs to really cause a lot of difficulty breathing, then they might try some diuretics to see if they can pull some fluid off the lungs. But your first line is going to be your corticosteroids. Anticoagulants. So one of the things that they lose in addition to their immune globulins, their protein, is clotting inhibitors. So if you're losing your clotting inhibitors, you're more prone to what? Clots. Yeah. And so sometimes they'll need to be on anticoagulants for a short period of time. But they'll run labs, PT, INR, PTT. They'll look and see what those values are to make sure that they're not at a risk for developing clots. And then your ACE inhibitors, can reduce your proteinuria, but you have to be careful because it increases that potassium, right? And so with this one, the ACE inhibitors can reduce the proteinuria, but that balance, you have to be really careful. And so that's where albuterol can be helpful here too, is to pull off some of that potassium. Your ACE inhibitors reduce your intraglomerular pressure, and that's where you have all that inflammation and all of that pressure in there. Your corticosteroids are going to take away the inflammation. ACE inhibitors will reduce the pressure, and then we'll be able to get rid of some of that extra fluid in the tissue because you're going to diurese it. You're going to have less pressure, so you'll be able to excrete the fluid.
If you combine an ACE inhibitor with like a potassium wasting diuretic, since you are reducing that proteinuria, so pulling it into the vascular system, and you're increasing the output with the diuretic.
You could, but diuretics are usually only for the respiratory compromise because it's not a salt water thing, it's a protein balance. And so that's where your corticosteroids are going to be your first line. Mm-hmm. If your potassium was climbing and you did have a pleural effusion or some dyspnea, using a potassium wasting diuretic would be a beautiful idea. Yeah.
Okay, so only with respiratory compromise.
Only with respiratory compromise. And then the albumin by IV administration is not often. So for a while, they tried to give them albumin. You would think that that would work really well, but it has a very short half-life and it's very expensive. So they tried to treat with all of these other things. If they are really struggling and this kiddo is just kind of circling, I guess, circling in the drain, and they're really, really struggling to get that protein back up and these other medications aren't working as well, then they will go ahead and try albumin, but it's really more of a last resort. All right, so diet, moderate protein, low sodium. Because we're losing so much protein, even though protein's kind of hard for the kidneys to break down, and we have an acute kidney injury going on here, we still need to, it ebbs and flows, right? We have remissions and recurrences. This can last for a period of time. And they've lost so much protein that we need to not limit their protein a ton. But we don't want to protein pack them because that's where the pendulum went for a while. And they wanted to protein pack everybody and give them really high protein diets. And then they found that you could exacerbate your kidney injury. So now they've kind of hit the middle, which is really nice to have the resource that I have with when I did dialysis nursing. One of the doctors that I worked with, I was like, I'm seeing this in the research. Tell me more about it. And he said, yeah, that pendulum kind of swung too far this way, and now we're kind of back in the middle where they say moderate protein. Low sodium, restrict fluid and potassium. Daily weights. Daily weights are a solid, good indicator of weight gain, of fluid balance. So even though you're doing your I's and O's, it can kind of creep up on you that somebody was a little fluid positive, and then they were a little fluid positive, and then 3 shifts later, they're a little fluid positive. So they really should be on a daily weight so that they can see how much fluid they're hanging on to and see what that relationship is. So that is a very dependable measurement. Measure the abdominal girth, because these guys can have ascites, right? They can hang on to so much fluid that their little abdomen will start to swell. If you measure abdominal girth right over the belly button and then mark it with a Sharpie, just right where you measured so that everybody's measuring right at the same spot, so you really get a good reading, because sometimes somebody will be just a little low or just a little high, and so the measurement will change. Vital signs, keep track of your vital signs. Ongoing assessments for skin, nutrition, and edema. And then your infection prevention. Tell them in their teaching to stay away from sick people because their immunity is affected, the loss of those immune globulins, right? And it has remissions and recurrences, so they will be out in the community at some point as they start to have a remission and they're getting better, and they need to make sure that they don't, they're not around sick people. Okay? All right, we'll finish this one here in the next slide or two, and then we'll take a break. Prevent skin breakdown by turning them, Q2. I's and O's, and then patient and family education. There's a lot of things for them to be aware of when we send them home. Their dietary intake, their skin assessments, their weights, watching their I's and O's. And so there's a lot of teaching that we need to make sure that we do before we send these families home. Okay, so before we start HUS, we'll take a break, go for 10 minutes, come back at 20 after. We'll finish this and then do our activity. Does it feel like we're going really fast?
No.
Because it usually takes me a little bit longer. So I feel like I'm just like
You're doing great.
going out of clip.
Yeah, I'm okay with that.
You're okay with fast. Just as long as it makes sense. You know, as long as I'm okay with fast too if it's making sense to you.
It makes so much sense.
Okay.
Oh my gosh, I'm like a baby.
I know, I'm watching so many of you guys do that, so I guess fast is good, so you can, no, I know, I watch all of you trying too. Hopefully with our little activity at the end, this is our,
I do not have goggles or facial.
what? Well, you have your glasses, and you have your mask. Yeah. And we'll be small, it'll be really small groups, because I was going to put you in 6 groups, and there's like, what, 2, 4, 5, 6, 7, there's 8 of you. So it'll be kind of like 2, 2, 2, 2. I might have to draw one. But then we're going to have them online do something too. So we're going to I have these big pads of paper, and we're going to draw out some of the, like one of you will do clinical manifestations of one of the illnesses, and one will do therapeutic interventions of that same illness. So you can pull out your notes, and then you can draw it out. So I'm going to have them do it with a whiteboard online. I got to get my big pads of paper here.
Oh, I'm so cold too.
Are you? You want my jacket?
I have a jacket.
I know, but I'm dying. Maybe it's this light. I don't know.
Also because you're teaching.
Yeah, it's 71, which
Oh, yeah. No, I'm not.
I'm a little warm with anyway. We keep our house at like 68. But it'll be so nice this afternoon. You'll have to go outside. I think they said 70 today or 68, Kylie. We're supposed to be 71 today, tomorrow and Thursday, 73 on Friday, and 46 on Saturday. Welcome to Utah. And then rain and snow, and then 37 on Sunday. Like our overnight lows for the next 4 days are higher than our high. Are you guys snow lovers or summertime lovers?
Summer.
Summer. Oh. They're so dang expensive. But my sister, like, what a season pass, like up by me at Powder Mountain or Snow Basin, season pass is over like $1,000. And
use their buddy passes, because like they'll get them and they'll come with like 2 buddy passes. So the amount of times I can go, because then it makes the day pass like $40.
oh wow, that's great. My sister lives in Idaho, and Bogus Basin is there, and she can buy her entire family, 6 of them, a season pass for $1,200. Yeah. She's like, that, you guys are such snobs about your snow. I'm like, I know. We think we're so great that we can charge so much money. Yes. All your equipment.
And you don't buy that new stuff every year, but yeah, but
Yeah. When you have a 15-year-old like mine that grows every 5 seconds, I'm like, I'm not buying you equipment. You will rent. He's like, well, really, I don't know if that's counterintuitive to how much it costs. I'm like, no, I'm not buying equipment for you when you grow leaps and bounds every couple months. He told me yesterday, he goes, Mom, I have 2 pairs of pants. I was like, what? I bought you like a ton of pants in the spring, in the fall. 11 pairs of pants from August to December.
oh my gosh, none of them fit.
And none of them fit. And then in the spring, I bought him 4 more pairs of pants before I said, wear shorts. It's almost summer anyway. And so he had some that were a little shorter that he would wear when we'd go camping or, whatever. And so then he said he was going hiking with his brothers over the weekend. And he put on his sweats that he normally wears for like pajamas. What are you doing? And he goes, I have 1 pair of pants that fits me that I wear to school. And one that's a little short, so I wear the same color socks. And these. I was like, dang. And Christmas is 2 months away. I don't think it's really fair that I get stuff I need for Christmas. Like, well, just be glad Christmas is there. So that you get the stuff that you need.
My birthday is like right next to Christmas. So it's like happy birthday next Christmas.
Oh, yeah. You're like,
No.
no, this is not fair. Other people get both. Yeah. What day is it?
The 21st.
Oh, okay.
My dad's is the
Yeah.
22nd, and he still makes the celebration separately.
Yeah, Renee's is the 23rd, and Natasha's is Christmas Day.
My dad's Christmas Eve, but he doesn't go back.
She doesn't know that, do you?
My older brother's is the 27th, and we always pay the day after Christmas. Decorations are gone.
Yes. Oh, yeah.
Birthday.
Because then it's birthday stuff.
Birthday, Christmas.
Yeah, I think that's so unfair.
Birthday. Oh, it's also like Christmas Day.
Yeah.
$5
And it was friends, so it's not your Christmas. Okay, that's my mom's Yeah, they got the house.
I have one son whose birthday is July 20th, and it's like almost exactly 6 months from Christmas, And he's like, so every 6 months, I get something.
Yeah, nothing wrong with that.
I know. It's hard when they all get older. You're like, I hate to just, like, I'm a present opener kind of person, but my oldest just got married, and they had to get a little bit bigger apartment. He has this tiny little 1 bedroom, so they just moved into a bigger one so they can use money, and they're going through immigration stuff, and so lots of money. My second one is just finishing his bachelor's degree, so we're like, well, I want to give you something more than just Christmas money, maybe something for graduation. My third one just bought a house, and so he can use the money. And my 15-year-old is just like, well, if you're going to give everybody else money, might as well give me money. I'm like, well, this is lame. You just like, here's an envelope for Christmas. I don't know. I'm like, what's that? One year, my mom always gives them like $50. And one year she's like, do something creative for me, would you? And so I bought those gag boxes, those gag gift boxes. Have you ever seen those? And you just buy the box, and the box has like a made from TD order now, on the market or whatever. And they're just gag gifts. And so one of them was a GoPro for your dog. And so my son had a dog, and he was a big hiker and stuff like that. And so he was like, this is amazing, but it was full of ones. Like I put 50 ones in it from my mama, but I put like a can of soup or something, so it felt kind of heavy. He's looking it over, and he's like, oh my gosh, that's so cool. I'm like, that wasn't supposed to be their response. And then my older one, at the time, was the only one that drove, and it was like an LED thing that you could plug into your lighter, and it would put your message across the back of your or like your back window. So you didn't have to put bumper stickers on your car. You just change what it said. Yeah, and it was a gag box too. And then one was musical slippers. So they had like a radio in them, and it was Bluetooth to your phone or whatever. You could just walk around. Yeah, anyway, they were funny. And so I made them all open them exactly the same time so that somebody didn't see there was just money. And they're all reading them and actually thought they were pretty cool, except Logan's, my youngest. It was a video game that was helping clean the house and the yard. So it came with a little rake and it came with a like, what? So it was pretty funny. And then they opened it and they all had the money from my mom in there.
Yeah, I'm not good at preparing myself.
Okay, let's go. Let's go. Okay, hemolytic uremic syndrome. So this HUS is the one that is not in the book. Red blood cells are destroyed, and they block the kidney's filtering system, the glomeruli. So the first one, we have an immune response. The second one, we're losing so much protein. So these are the things that are gumming up the system. Now we've got red blood cells that are being destroyed, and they are what is clogging up the kidney's filtration. It's a sudden and temporary loss of kidney function. And here's your classic signs, this little triad, hemolytic anemia. So it's not anemia because we don't have enough iron, right? We're breaking down red blood cells, and now we've got anemia. Thrombocytopenia. So the thrombocytes, or your platelets, go to the area of injury, which is in the glomerulus. And it also then will make it hard for the blood to be filtered through. So you've got these red blood cells, you've got these platelets that are all kind of gummed up in this area. Because the platelets are there, but you don't have as many that are circulating. So you'll have thrombocytopenia. And then acute renal failure. They can go into complete renal failure with this one. So your typical HUS versus your atypical. So typical, the biggest cause is E. coli. It has a sugar toxin. So when you break down E. coli, one of the byproducts is this sugar toxin. It comes from uncooked meat, most often ground beef, unpasteurized or raw milk, unwashed or contaminated raw fruits and vegetables, and contaminated swimming pools or lakes. And so that's where a lot of the swimming pools say not just a swimming diaper, but now they want plastic pants over the swimming diaper. And the pool by us does pool checks every 2 hours on the even hours, and they just test the pH and stuff in the pool and kind of do a check, I guess, for anybody that might be struggling, but also any floaties that might be in the water. And so they say, when they make those announcements, they say, everybody out of the pool, we're going to do our pool check. Please take your children and change their swimming diapers, which is good, but it's not real practical for a lot of people, because if you go swimming for 6 hours, that's 3 swim diapers, and they're pretty spendy. And so some people won't change them. And so that's why a lot of them are like, okay, now we're going to put plastic pants over swimming diapers so we can keep from getting these contaminated swimming pools. Shigella is also a bacteria. You don't see it a lot here unless it's brought back from abroad. Usually third world countries can bring back Shigella. My mom traveled there when I was about 18 months old, came back with a case of just like what she thought was traveler's diarrhea, and I got Shigella and almost died. So when you're doing your assessments and you're getting your history of what's going on, ask about all of those assessment pieces that go with stool output, because it's white, kind of a light gray to a white. And then salmonella, typhi, or typhoid fevers, parasite that they can get that will also cause HUS. Over here, you have the atypical or the non-sugar toxin. So strep can cause HUS. Drug-related, so chemotherapy, bless you. So chemotherapy can cause this, and malignant hypertension. That's not super common for children, but you can get HUS as an adult too. All right, so your HUS pathophysiology, just here's a little bit about kind of what's happening. So the toxin damages, so you have E. coli, it damages the glomeruli, then it damages the red blood cells, and then they break down, and then they sit in that glomerulus and cause, and it has hemolytic anemia, but it kind of gums it up, so the filtration is poor. Then you have damaged red blood cells that clog the kidneys filtering system, causing renal failure. The platelets cluster where the damage is, and that causes thrombocytopenia because you have all of them in this one area, and you don't have enough circulating. So if you don't have enough circulating, what can go wrong? What's a problem? They're at risk for what? Bleeding. Mm-hmm. And we can't afford that, right? Because we've got this hemolytic anemia going on. We can't afford to be losing more blood. And then the concerns are kidney failure, hypertension, heart problems, and stroke. Because you have these damaged red blood cells that have broken down and clusters of platelets, then you can have microclots, microthrombi, and they can lodge in very small vessels and cause heart problems and strokes. One of the big clinical manifestations is hemorrhagic colitis or bloody diarrhea. So now we have all this hemolytic anemia, and we're losing the red blood cells. They're moving through the system, and you've got all this edema, so they're holding on to fluid, right? Because our damage is in the kidneys, and so we're not reabsorbing. We've got it all out in the tissues, so you've got it through all of your intestinal tract, and now you've got all this extra blood, so they have bloody diarrhea. They don't have that with the other two. Severe abdominal cramping, nausea, vomiting, and anorexia. This can be the urea, the buildup of urea that's the same for the others. But also, if you have hemorrhagic colitis, so you're having this bloody diarrhea, do you feel very much like eating usually? No, when you have massive diarrhea and you're not feeling good. And then generalized edema, so they can have periorbital edema, they can have ascites. This is the same as the others, the oliguria, not much urine output. Those kidneys are not filtering through things. Hematuria and proteinuria. They will have some red blood cells and some protein, but the first one, were you raising or just stretching? Okay.
Which one would you say out of three has mild edema?
The first one, excuse me, the hypertension goes higher, but usually you'll just have periorbital or a little bit maybe in their fingers. Massive edema in the second one, and then nephrotic syndrome. And then this one, they can have the periorbital, they can have some ascites, but not as prone to it as this because of the diarrhea, because they're losing a lot of fluid. Okay, does that help you a little bit? Let's see, pallor, so they're very pale, losing lots of red blood cells, and then a real toxic appearance. So the best way I can say that is you see kind of this yellowish color. So they're not jaundice and they're not real pale. They just kind of look a little bit toxic or a little bit sick. I don't know. It's a little bit difficult to say, just kind of this yellowish color, but it's not jaundice yellow. Hypertension, it's not going to be as high as the first one. So the first one, the acute glomerulonephritis, has marked hypertension. But they can be a little hypertensive with this. They won't always give them antihypertensives though. Usually they will end up needing dialysis, and that will pull off fluid anyway. Here is the big difference with HUS. The others do not have a neurological component to them. So you've got altered level of consciousness, irritability, seizures, coma, stroke, and brain injury. So you have that. This is particularly with the E. coli. So the non-sugar toxins, like the strep that were on this side, so we'll go back to there. Drug-related chemotherapy, malignant hypertension, these aren't as high risk as causing these neurological involvement symptoms as the E. coli, the sugar toxin causing. With altered level of consciousness, they can just be a little confused. Clear to being in a coma. The whole range in between. They can be very irritable. I've seen them have seizures. I've seen a couple of people that were left with a seizure disorder after they had had this acute kidney injury and ended up with neurological issues and ended up having seizures. I did know one little girl who had a brain injury that didn't resolve. So when they finally got her off dialysis, finally got her kidneys a little healthier, she still had a brain injury, and it was pretty significant. And then I have seen other kids that have been in a coma. I haven't seen a stroke. So putting them on contact precautions, fluid restrictions, fluid and electrolyte replacement. So restriction, replacement. You got to be very judicious, like how we talked about before. And you don't want to be giving a fluid that has potassium in it. But they might need a little bit of D5, right? Because they've got this massive diarrhea and no appetite. And so we might be struggling a little bit with a blood sugar. And so giving them just a little bit of D5 at a slow rate so that they've got something to help maintain. But you don't want to, but you want to restrict the overall per day that they can get. So like an IV plus PO of say 1,500 mils, like a liter and a half, right? And so you don't want anything that's liquid at room temperature counts. So Jell-O, ice cream, soup, drinks, all those kinds of things, popsicles, they all count as fluids. So you have to be really, really careful and limiting their salt. That might be on the next one. Limiting their salt will make it so they're not as thirsty. And adding lemon to something can actually quench their thirst. So just a little bit of fresh lemon in a little bit of water will help quench their thirst. We learned that with some of our dialysis patients that had really severe fluid restrictions, that if they had like some lemon drops or if they had a little bit of lemon in water, they weren't as thirsty.
Practice.
What's that?
Would that be an evidence-based practice?
No, yeah, in our evidence-based practice sheet for clinical, I don't know. It might be a clinical, the clinical piece. You know, we just know that it works.
Yeah.
I don't know that there's science behind it, but we just know that it works. You guys know what we're talking about, right? Those 9 boxes that you have to do in clinical.
Yeah.
Yes. So if you need a box filled with the clinical experience box, there you go. We just know that lemon works like that. All right, IV nutrition. Sometimes they will need a little bit of TPN. If they're sick for a long period of time and we're having bloody diarrhea and no appetite, they might need a little bit of IV nutrition. So that would encompass this. You wouldn't give them in addition fluid and electrolyte replacement. You would then give them the IV nutrition because it will have some electrolytes in it. It has all kinds of nutrition in it. The trick with TPN is, which is total parenteral nutrition. It's kind of a yellow looking bag if you haven't seen it, but it is hard on the kidneys after a while. So you don't want them to be on it for a really long time because then it can be kind of hard on their kidneys. Their labs, CBC, you want to watch that because they're losing so many red blood cells. Their H&H will be very low. And sometimes they end up needing to have a blood transfusion. Stool test, that'll tell you if it's E. coli, if it's Shigella, whatever the cause is. Urine test, you're going to look for that BUN and creatinine being up, that GFR being down. So these are going to be same kinds of labs as the nephrotic syndrome and the acute glomerulonephritis because it's all kidney injury. And then a kidney biopsy, they will generally do it with this to make sure that they've got the diagnosis right. Ongoing assessments with your body systems, and we'll walk through the body system ones on the next slide. Frequent vital signs, monitor their blood pressure closely to see if they're going to go high enough where they need antihypertensives. But most of the time in my experience, they have not needed that. They just sit just high enough that you need to be watching it. Daily weights, strict I's and O's, transfusion of red blood cells and sometimes platelets. Medications, so antihypertensives or diuretics. So with diuretics on this, will they need them often? Because you have, will they need diuretics often? I don't know if you can see what I'm pointing at on there, but I'm pointing at diarrhea. So they're not going to need diuretics often, right? If they're holding on to too much fluid in the tissue, then we will need to give some to pull it back in the vasculature. But most of the time with the diarrhea, they're not going to need a lot of diuretics. So, but these are some that you might see. And then dialysis. It is very common to need dialysis with this one. The other two, not as common. And so they'll put in a catheter, just usually a subclavian that has 2 ports on it. And then they can run in and out. And it creates a loop so that they can take the blood out to the machine, clean it, pull off the fluid, and send it back through the other. So they will be labeled red and blue. They'll have red and blue caps on them. Your red would be your arterial, right, that's leaving your body. And the blue cap is going to be your venous that is coming back to the body. And so then they can clean it, pull off fluid, whatever they need to, then heparin pack that and keep it ready for the next dialysis treatment. Unfortunately, they don't let you use it. When it's for dialysis, it's only for dialysis. So if you have to draw labs, you usually have to have them be poked, or now they have those newer catheters, the IVs that you can draw from, have the little port on the side. I forget what they're called. Pivos, yeah. And so then you can, has the little port on the side that you can draw from, a peripheral IV, which is really nice, especially with peds. When you had lots of labs, you had to just keep poking them. It was really kind of a bummer. All right, so nursing interventions, 2 things to remember with this. No antimotility, so no Modium. Why? We have what in the body? Lots of toxins, right? We've got this E. coli that's wreaking havoc on our little body. And we have this bloody diarrhea, but it's also getting rid of the E. coli and the Shiga toxins. And we don't want to hang on to that. So they'll just let them have diarrhea and they'll fix it how they need to on the other end. And then no antibiotics. It can cause further damage. So for a long time, they thought that antibiotics were a good thing to give them. I don't know what the exact thinking was behind there, because the only bacteria, I mean, yeah, I guess I could see, I don't know the research behind it. I guess I could kind of see why they were doing it. But they started to find out that kids that were receiving antibiotics had further kidney damage than kids who did not receive antibiotics. So they started to do a lot of research studies. There's a lot out there, and they all came to that very same conclusion, that this causes further damage. So if you have a child that has HUS and they prescribe antibiotics, definitely have a conversation with your practitioner and just tell them that my understanding is best practice is that you don't give antibiotics when they have HUS. Is there newer research? Is there something that I don't know or that I'm missing? Because my understanding was that can cause further injury. And just have that conversation with them off to the side. Obviously not in front of anybody, because it'll make them feel bad. But make sure that that's something that you visit if they do order that. All right, your ongoing assessments. So neurological, you're going to look for level of consciousness changes, irritability, seizures, stroke, aphasia, and dysphagia. So aphasia, if you have a child who was previously talking to you, or talking when they came in, and now it's getting worse and they're not speaking to you, or they have an altered level of consciousness, then it's definitely a call to your practitioner to say things are getting worse. Respiratory, look at their breath sounds and their blood gases as needed. So if their breath sounds are very crackly and they have a lot of dyspnea, maybe they have some oxygen needs, they're tachypnic, then definitely get some blood gases on them. Even just a cap gas, just a capillary blood gas, so that you have a baseline. And then cardiac, hypertension, edema, and signs and symptoms of congestive heart failure. Because if they hold on to enough fluid, then they can actually, if it's around the heart, kind of like pericarditis, they can actually tamponade that heart, which has put too much pressure on it and make it too hard for it to beat. With GI, hemorrhagic colitis, dietary restrictions. So we want low sodium and we want lower protein. So here we go. First and last, acute glomerulonephritis and HUS, we want to limit our protein intake. But nephrotic syndrome, where we're losing massive amounts of protein, we want moderate protein intake. Okay. GU, oliguria, anuria is none, no urine output, and hematuria, where there's some blood in there. Looking at their skin, look at any breakdown related to their edema and immobility. Musculoskeletal, they're going to be very weak, very anemic. Don't just stand them up. They'll crump on the floor. And so make sure you do orthostatic blood pressures on them, because they're not always hypertensive. More often, they're hypotensive because we're losing all those red blood cells and having a lot of diarrhea. And then psychosocial, it can be pretty anxious and pretty sleepless. They're anxious because obviously they don't feel good, but sometimes their level of consciousness is just enough less. They're not understanding. They're not understanding why they're there or what's happening or what we're saying, and they get a little anxious and nervous. All right, prevention. Wash those fruits and vegetables and wash your hands. After a restroom, petting animals and handling raw meat. Those little traveling petting zoos, they're horrible. They're absolutely horrible. Little kids love them, and I can tell you that I took my children to them, but they're horrible because you go and you pet these animals that have pooped and peed in their pen, and then they've laid there, and then little kids are petting them, and then they leave and they touch their face, and you get it. So a lot of those little petting zoo things will now have a little hand sanitizer station or whatever. But I would just tell parents that is a risk, and maybe taking some antibacterial hand wipes or something, tucking it in their little backpack or their little diaper bag or something is very helpful. Using swim diapers and plastic pants, safe drinking water, thoroughly cooked meats. And this was something that I didn't know. Avoid unpasteurized products like milk. I didn't know that. But apple juice. Unpasteurized apple juice can cause problems. I didn't know pasteurization was a thing with apple juice. All right, so in the back of your book, or at the end of this chapter, there's this little sheet like this that tells you, that kind of breaks it down, and that's what gave me my idea for the little learning activity. It says Peds GU. What is it called? Peds GU handout learning activity. And it has the 3 columns. And at the top, it'll say acute glomerulonephritis, nephrotic syndrome, and HUS. And then it has all the words at the bottom. So for our activity now, I'm going to change this here and close it out and go back to my blue button. Friends. There we go. Okay. So here's what we're going to do. We have 2, 4, 6, 8, 10. Well, that works pretty good. Okay, so in groups of 2, so maybe if you want to come down here, we'll do 2, 2, 2, and then you guys together. You can come right down here, down front, and then 2 here. And then that'll leave a 6th one that that we can just kind of talk about. But what we're going to do is we're going to take these big pads of paper and some markers. I'm going to take these big pads of paper and some markers, and I'm going to give you a topic. So like you two could have clinical manifestations of acute glomerulonephritis. And you're going to draw it out however you want. Lots of pictures, columns, words, whatever you want. And I've got markers so you can do different colors, okay? And then, so just find a place if you want to go to the big table outside of my office. If you want to sit right here on the floor, if you want to go to the classroom right next door and sit on the floor, if you want to sit on the stairs, however you want to do that. We'll split up a little bit and we'll take about 20 minutes to do it. And then we'll come back and we'll talk about what you did, okay? So what we'll do, you guys will have clinical manifestations of acute glomerulonephritis. And then in the back, you guys will have interventions for acute glomerulonephritis. You guys will have clinical manifestations of nephrotic syndrome. You guys will have nursing interventions for nephrotic syndrome. And then you guys, do you want clinical manifestations or nursing interventions of HUS? Clinical manifestations of HUS. All right, hang tight online because I've got an activity for you too. So don't go away. I'm going to give them their papers and markers. All right, so watch your time. Come back about 7 after from wherever you decide to be. Okay? Here you go. Uh-huh. All righty. You're welcome. Does it have paper? Okay. It was lighter than the other ones. I wasn't sure there was paper on it. Uh-huh. Okay. And make sure you guys have your either goggles or face shields if you're right next to each other. If you're taking turns drawing and you kind of stand back a little bit, that's okay too. All right. And then draw it out, like, yeah. So make a picture of what it is. Draw pictures of it. You can do whatever you want. I'm terrible at drawing. Terrible. And I can do it. Me and stick figures, we are friends. Okay, you guys online, this is what we're going to do. While they are drawing their pictures, there's markers right behind that paper for Kim. While they are drawing on their pads of paper, I'm going to divide you guys into groups. So I'm going to put you into, let me see, there's 31. Wow, that's awesome. Okay, so probably put you in 6 groups. In those 6 groups, what I want you to do is decide, I'm going to give you a topic, whether it's clinical manifestations of nephrotic syndrome or nursing interventions of HUS or whatever. But I will tell you what group you're in and what your topic is. And you guys will get together for about 5 or 6 minutes and decide what you're going to draw and who is going to draw what. Then I'm going to bring you back to me and I'm going to give you a whiteboard. And I'm going to make it a community whiteboard. And then you guys are going to, I'm going to say group 1, now you draw. And you're going to have the opportunity to draw just like they are doing on their pads of paper. Okay, so is that clear as mud? All right, so I'm going to put you guys, I'm going to create some breakout rooms. I'm going to do 6 breakout rooms. And I'm going to randomly assign it. All right, please pay attention to what I tell you about who is in which group and what your topic is. Group 1, Megan Johnson, Braden Sanders, Fernando Saucedo, let me get this down here, Mark Richards, and Chelsea Hall. You guys have clinical manifestations of acute glomerulonephritis. Room 2, Emily Doxey, Olivia Hughes, Shelby Fulmer, and Aslan Clark, and Shelby Childs. You guys have nursing interventions for acute glomerulonephritis. Room 3 is Emma, Stephanie Packer, Hannah Cole, Maddie McMillan, and Jessica Carter. You guys have clinical manifestations of nephrotic syndrome. Room 4 is Amy Cooper, Victoria, Madeline Hill, Megan Birmingham, and Brooke. And you guys have nursing interventions of nephrotic syndrome. Room 5 is Madison Elwell, Dakota Cummings, Sydney Racine, and Maya Hadley. And you guys have clinical manifestations of HUS. And room 6, let me scroll down here, Marin, Taylor, Ashley, and Megan Bowman. You guys have nursing interventions of HUS. So I'm going to give you guys about, about 7 minutes. And then I'm going to bring you back to us, and then I'm going to give you a whiteboard for you to draw. Okay? Does that make sense to everybody?
Chantel?
Yeah.
Do they need to be like actual pictures, or can we just do the words?
You can do the words, you can do pictures, you can do both. I've had, last semester, I had people just take turns, like one person drew frothy urine, and one person drew a patient sitting on a toilet, and one person drew a lab value, so you can do it kind of however you want. So take the next 7 minutes in your group and decide how you're going to do it, and then we'll come back and you guys can do it on the whiteboard.
Hey, Chantel.
Yeah.
It's Megan Short. On Big Blue Button, it kept giving me like that I was an unauthorized user in the conference, and it kept kicking me out. So I've just been on my phone listening, so I don't have a group now. So what you guys can do.
Okay. Tell me. Let's see. Why don't I put you in group 6, which is nursing interventions. So look through that a little bit. I will jump into the group and tell them that you're in that group. And then you come back to draw on the whiteboard. See if you can draw on the whiteboard.
Okay, perfect.
Okay. It is so hot in here.
We've got forensic.
Okay, room 4 is doing okay.
Material proteinuria. But it wouldn't be a lot. No, it'd be like a dot. A little bit. Oh, sorry.
Algeria. Beautiful. What coach is this? I think it's the coach is okay. What coach has to do?
Power.
Hypertension. 180 over 90.
Ooh. You guys are pretty good.
We're fun.
Now you just need to turn it into that.
I guess. Everything comes to always.
Oh, son of a.
Why didn't you tell me? Because I was used one of your arms. I was like, you're turning your arm. Look at him. He's struggling.
Struggle me.
Obviously.
I hate you.
I am good. When you say hypertension,
It's kind of
okay.
we need to write right here.
Ladies?
I'm not.
Good.
Where'd he go?
It might be.
Oh, purple.
Yeah.
He looks like he's got an
Brain injury.
I'm gonna put blood diarrhea instead of bloody. Oh, it's gonna be weird. You didn't delete it, so. I don't know if. I don't know if when I went to the bathroom, if I overall. Something seriously smelled like urine there for a hot minute. I'm all, well, I don't know what happened.
Okay.
It's really sad. So like, one of my friends got COVID, and her freaking grandma just had colon cancer for like the last 5 years. Just got it. You know, I'm like, oh god, so sad. I see her, she's like, I love you so much.
Okay, it looks like they're back. All right. Okay. Can you guys hear me on Blue Button, Group 1?
We can hear you.
Yeah.
Okay. All right, I'm going to make this a shared whiteboard. And you guys have clinical manifestations of acute glomerulonephritis, right? Yes. Group 1.
Yes.
Okay.
Yes, I do.
All right, perfect. I'm going to make this a community whiteboard, and I want. Oh, wow. I'm going to quit talking when it's shared because apparently my mic has a feedback loop or something in it. So I'm going to make this community whiteboard, and then Group 1, I want you to draw your stuff.
November, which means it's officially no shade. I don't know, you like that.
Can you see them? Look at that. They're doing all their beautiful artwork.
Heavens.
You're doing great, Chelsea.
You guys are great. I love it. You guys are so good. Oh.
Oh, someone found the tool.
Yeah. Yep.
Diaphoresis?
I think so.
What is diaphoresis?
Ding, ding, ding. You guys are doing so good.
My drug
Have you guys tried to draw on there?
No.
Oh my gosh. If you draw on the mouse pad and it's kind of okay, but when you draw with the mouse, it's kind of, I'm left-handed, so but I'm mouse right-handed. So to try and draw with the mouse is kind of crazy.
I always use my pad because I have a laptop.
Okay, look at you guys. That is so great. Okay, so tell us about your oh, Fernando's almost done, Chelsea's almost done. I'm gonna have you tell us about your picture.
What the heck are you drawing, Chelsea?
Guys, it's really hard. Don't worry.
I love it, Chelsea. You're great. I don't know what it is, but it's great.
Okay. You're great. I love it.
Oh, God.
I'll explain it later.
I don't say that went out in the hall just now.
Is that a heart?
Okay.
Oh, blood.
Lots of blood in there. That's very good. Okay. All right. It looks like you guys are done or about done. All right. So tell us, one of you guys enable your mic and tell us about your picture.
Okay, I'll just start since I'm done. So the clock is for its acute onset. And then that's a clock. And this is going to be the protein area. So there's the protein, but then in the blood, you're going to have lower protein. So that's a hand. And then this is supposed to be like the veins in the arm. And then, yep, there you go.
There you go. I think that's great. And it looks like there's a lot of blood in that urine too. So that's a good thing too. About all your blood and arrows. Okay. How about Mark? What did you draw? Maybe he doesn't have a mic. I don't know.
Yeah, he's typing.
Oh, my God.
Okay. Well, why don't you, Chelsea or Fernando, one of you guys that has a mic, why don't you tell us about the other pictures?
I've got, oh, go ahead.
You go ahead, Fernando.
Okay. I've got edema, the official periorbital couldn't really do that, but and then the hematuria.
Okay.
Yeah,
And
just to
then,
look.
and then what else? What are the other ones for us? Can you tell us, Fernando, what the other ones are?
So let's see. It looks like we've got I'm not sure which. Let's see.
Marked with the nitrogenous waste
Okay.
Perfect.
and a fever. So there's a thermometer.
Beautiful, Marky.
Okay.
What did Braden have?
Does Braden have the pain and like they're sleepy?
Yeah, they're tight, lethargia.
Okay.
Sleepy.
And then bottom left corner with the urinal. Was that Braden that was drawing that?
I don't remember.
He says scant urine in the urinal and increased blood pressure.
And then
Perfect.
we also have the abdominal like flank pain.
Uh-huh. Good job, you guys. Way to go. All right. I took a picture of it, so if you guys want a picture, let me know. I'll text it to you.
You guys are way better artists than I am.
Okay. Now we're going to do group. Let's see. Come on. I'm trying to make it. There we go. Okay. Group 2. You have nursing interventions of the of acute glomerulonephritis. So ready, set, go. This is so hard to try and find an activity that can be done both. What's that?
Are you assuming that like the one group at a time?
Yeah, to just have them kind of draw their little thing. So those guys out there are coming back here in about 2 minutes. And then what we're going to do, we're going to take yours, because they're a Post-it note, and then we can just stick them up like across here. Well, your name's not on it. They could stay up, yeah.
No.
We could put them out in the hall.
Listen,
Also no. You know the whiteboards that are out in the hall out there?
Guys, they were supposed to be lungs, okay?
I know, that's me too.
Yeah.
When I went to nursing school, we did quite a bit of this, and then like associations and stuff like that to get through. But we drew a knee and stick figures.
Jack of all trades.
No, that's okay. I think it's funny.
This is so cute.
Is it?
We're
just drawing. I like it.
All right, look at you guys. I love it. You are drawing way better than I could with my.
No water, no bananas, no.
Yeah,
No.
just limiting the salt and the fluids and
I
the
mean, like the
potassium and. It's a banana. It doesn't look like a melon.
Hey, well, I know that it's spice of melon.
You guys, this is great. I love it. That's true. Okay, who has a mic in this group that can tell us what your pictures are?
I have one.
Oh, perfect, Shelby.
Okay, so in the top left, Olivia did to restrict salt and fluid and potassium and often protein.
Okay.
And then Aslan did in the bottom left corner that they're going to have an increased BUN.
I love it. There's your bun.
And then I did in the middle, so there's edema, so for lungs, and then just peripheral edema or in the skin.
Oh, that's a good one.
And then I believe it was Shelby Childs did the record the eyes and nose and then the vital signs.
Okay.
And just assess. And then Emily, or sorry, I don't know who it was. Did hand washing.
Oh, that's very good. You guys did a great job. I'm going to take a picture of that one too. So if you want it texted to you, then let me know. Good job, you guys. You guys see what they're doing it on the whiteboard too. Good job, you guys. All right, so we're going to clear that one. All right. Group 3, you are clinical manifestations of nephrotic syndrome. Ready, set, go. If you guys need to take a quick bathroom break or whatever, then come right back and we'll talk about the ones that you did. What is that? Puffy eyes. Who was it that brought? McKenna, did you bring back my markers? Was that you? I can't remember who had them yesterday.
I didn't borrow them last.
Oh, okay. I was trying to remember who had them last, but they were just waiting here for me when I came in. So.
Oh, I took yours.
Yes. Very good. It's a good heart. That is very good, you guys. What the heck? Maddie. Ah, there you go, little fat hands. That little feet. My goodness, that is really good. I'm very sleepy. These are so good. You guys always do such a good job. I love this. Good job. All right, who has a mic? Tell us about your picture. Hello. Who has a mic?
Okay, I turned mine back on.
Oh, perfect. Thanks, Maddie.
Okay, so his green cheeks are for nausea and vomiting. The little bags under his eyes are for the edema. The heart is for tachycardia. This right here is supposed to be ascites. And then he's got edema in his arms and feet. And then we've got weight gain, decreased immune system, pleural effusion, frothy, foamy urine, oliguria, lethargy, tachycardia, hypertension, and then remission and recurrence.
Good job, you guys. All right, same thing. I took a picture if you want it for your scrapbook. All right, so then we'll do, let's see, that's group 3. So we'll do group 4. You guys are clinical, oh no, you guys are nursing interventions of nephrotic syndrome, right? I think that's what they are. Does it help to have a little different way to look at it and see it? People do a lot just to feel it didn't help my drawing skills at all, but we did it quite a bit. We'll hang them up on our board and see them. Before I hang them up, I'll have you guys show them up there on the screen. So why don't you guys come and show it here while they're drawing. Okay, so you guys have acute glomerulonephritis? Okay, clinical manifestation. All right, you guys, so you guys that are here, you can turn around and show them what you've got.
Show them too.
Yeah, actually you could hold it right. Oh, and then we'll see their artwork when they're done.
Okay.
We'll let them draw behind the scenes.
Hello. Okay, so we have clinical manifestations for acute glomerulonephritis. And so, so the onset is abrupt, and so, yeah, it can onset as soon as 1 week after infection. And then we just kind of have the other clinical manifestations. So azotemia, so their BUN and creatinine would be high, their GFR would be decreased, and then they would also have some dry, itchy skin due to the nitrogenous waste in the blood. And then oliguria, or scanty urine output, and also proteinuria. So their urine would be foamy and low intravascular protein, and then they would also have some edema. So there's that picture of that little boy that had his facial edema and his eyes are really swollen. And
then there's abdominal pain, so it'll be nausea and vomiting related to that. And then, as you said, the edema and the facial edema is also going to be pulmonary edema related to the fluid overload. So that'll be like the top of the lungs and stuff like that. There's going to be hypertension also because of the fluid retention, and hematuria, which can be really good. It's just blood in the urine. And then fever, it'll be a low-grade fever, won't be anything super high. And I should have said the abrupt onset. And also, it's a mostly short-term illness, so it's an active meal.
Beautiful. Good job, you guys. All right, so then pull this little page off and just stick it up on the wall right by the screen there. Good job. Okay, look at this. These guys are just about done. Yeah, it's a big post-it note. And then the fun thing about that is before you guys leave, you can snap a picture of the other ones that people did, and then you've got, if this is a way to help you learn, then you can, then you've got some extra pictures. Okay, so then interventions of acute glomerulonephritis. So we'll do, you guys are about done on mine. Looks like. Okay, Brooke, I see your mic is on. Will you tell us about your picture?
Absolutely.
Okay.
So up in the top left, we have washing our hands to prevent infection, prevent spreading, whatever. And then, yeah, I think it was Victoria that kind of helped label them. So we're also measuring I's and O's, and we're we're measuring the abdominal girth. So that's a really and the big abdomen. And then down in the bottom right, they're not pants, they're just swollen legs. So that's the edema. And then we did I was supposed to be a thermometer.
Uh-huh.
For the temperature, and the low blood pressure cuff for the blood pressure, and then the heart for the heart rate. For vitals, because constantly just making sure their vitals are okay is a nursing intervention. And then this was supposed to be a skill.
Oh,
So
okay.
that
The
you,
little feet on the scale.
yeah, and that's the number that pops up. So
Beautiful.
there we
Good job, you guys. Thanks, Brooke. You guys, I love how clever it is that you guys are all just a little bit different. You know, edema looks, all of them have edema, but everybody draws it just a little bit different. Okay, so I'm going to have you guys draw behind the scenes for group, what was that? Or are we on nursing interventions for nephrotic syndrome? Is that our next one? I forgot what group we were on.
that's the one that we just did. We just did the nursing interventions for nephrotic syndrome.
Oh, that's right. Okay. So we're on group 5, which is clinical manifestations of HUS.
Well, they do it there and then we do it. So we're
Yeah, so we were just behind them. I got them started because they hadn't drawn it yet, and you guys were drawing. Okay, so clinical manifestations of HUS, and then you guys come up here and show those of us that are here what you got.
okay, so we have the nursing interventions for acute.
There you go.
Okay, so you would decrease their potassium, fluid, salt, and protein intake. And then you would monitor their eyes and nose with a little eyes and nose chart. And then you're just going to do vital signs frequently. And then, okay, you're going to want to make sure your patient is on precautions to protect yourself as well as them. You're going to want to be checking skin assessments, and a lot of times these patients are going to have edema, so making sure that you're documenting that. And then for meds, we have calcium channel blockers, diuretics, and then if the patient was on any previous antibiotics.
Thanks, you guys. I love it. Okay, so pull this off and then stick it maybe just on the blue wall. Usually they come off very easy, so I'm not too worried about it. Or I might end up painting, right? Okay. Okay, so clinical manifestations of nephrotic syndrome, because they're still drawing here.
Well, here we go. Look at this, you know the vibes. We out here.
Sorry, they're drawing right behind them.
You can't really tell, but like we're drawing straight. So yeah, no. So clinical manifestations, if I say that. We got diarrhea, diaper. We got some foamy urine, weight gain. That's what we got. I drew this little one.
With the scale.
It's not bad, and then we did it's like the lungs, so pleural effusion along with difficulty breathing, and that's why we do that first, the breathing. We tried to emulate that, and then increase heart rate, and we're gonna do like tachycardic. Then edema, that's why he's kind of swollen, got a double chin.
Got some bicep, we got some guns there.
Yeah, that's
That's all bad. It's all edema.
It's edema. Ascites right here because of the increased fluid. And then the
periorbital
edema, if I can say that right. And then I think that's it.
That is awesome. So pull it up. Yeah, I'm going to come take some pictures of you guys. Good job. You can stick it maybe just on the wall right over here. All right, and then you guys that are on the screen, you look to be about done, I think. So who has a mic for those of you on the screen? Be brave. of you guys must have one. Are we just going to look at it and guess? Sydney, do you have a, or Maya, or I'm trying to think of who else I saw there. Ashley.
I'm in the next group. My mic or my cursor just accidentally went on it. So.
Oh, okay. All right, Ashley, that would be great if you would tell us about it.
I can tell you about it.
Okay.
Sorry, I was turning on my mic. We just have some hypertension with increased blood pressure. I tried to draw oliguria, so decreased urine output, head injury, edema with the big legs, ascites, swelling in the stomach, and just like a altered level of consciousness, some abdominal cramping.
That is very good. I love the headache with the hammer. Okay, good job, you guys. I'll prove that. So, all right, so that was our clinical manifestation. So the last group for online would be the nursing interventions for HUS. Okay, and then while they're drawing, all right, nursing interventions for HUS. All right, so then you guys have nursing interventions for nephrotic syndrome. Okay. Oh, perfect, thank you.
Okay. So, nursing interventions. We're going to give corticosteroids to decrease inflammation and ACE inhibitors to decrease the pressure. And decrease fluid intake and decrease potassium, abdominal girth measurements, daily weights, moderate protein, low sodium. Infection prevention, so we've got some hand washing, we've got some hand sanitizer and wear your mask, and abdominal girth. Yeah, we've got that twice.
That's okay.
Arthros, UTR Yeah,
You guys are good drawers. Holy smokes. Good job. You got them all on there that you own your mask. Very cute. Good job. All right, stick it up on the wall. Or maybe you flash it for them on there so that it's on the recording. Let's see. Maybe when we clear the whiteboard again, maybe I'll put it up there and then we'll tear it off. If you leave it with me for a minute. Yeah. Good job, you guys.
I would high five you.
I would be. Oh, let's see. All right. And these guys, you never knew that you guys would all be such good drawers by the end of nursing school, right? Okay, well, let's see, they look like they're finished. Okay, so online, one of you guys enable your mic and tell us what you've got.
For mine, I did have PPE and dialysis in the bottom right corner. They're a little scary.
No, I think it's great. Okay, what else?
Then we've got anti-hypertension drugs, and this is someone sitting on the toilet peeing because we give diuretics, so they're going to be peeing a lot.
Then what else? Who else is on there?
For mine, you do not want to be taking antibiotics for this condition, and also you want to have fluid restriction, but also have fluid and electrolyte replacement. So
okay.
Water
Good job. All
and
right.
Taylor was in our group too, and she drew CBC, stool test, and urine test. So a bunch of labs. So we've got urine and poop, and then some blood right here.
Good job. Okay, I think was that all of them on there? Our sodium and potassium. Good job, you guys. All right, so then we've got, I'm going to show you, that's the last one online. So let me show you this one here. So it's on the recording, I guess.
I don't know why you don't play ours.
Well, I think because the other ones were, maybe there. The other ones were on there. So then you can see all that's on there. Okay, and then our last one was clinical manifestations of HUS. Okay, so this will be the last one here because we didn't have enough groups to do nursing interventions for this one. All right, girls, bring it on up. This is our friend. Oh, hide it. Oh, hi, Mark. All right. It's not that visible. Oh, is it? Sure. Doing beautifully. Okay, clinical manifestations of HUS. We've got hemorrhagic colitis or diarrhea, severe abdominal cramping, and nausea, vomiting, anorexia. There's some vomit, generalized edema and the ascites, periorbital, and oliguria, hematuria, and proteinuria. There's your little dots. Pallor, he's already pretty white. Toxic appearance, he doesn't look the greatest. Hypertension, blood pressure 180 over 98. Altered level of consciousness, irritability, very irritable. Seizures, coma, stroke, brain injury. One people bigger than the other. One bigger than the other. I love it. You guys are so clever. And they don't, I mean, they're really similar things and they don't all look alike. I love that. Okay, let's hang it up on maybe on this other side of the screen here. Then I'm going to snap some pictures and of all of them. I know, that's the thing. Okay. All right, you guys, so that's the end. We're done. I'm going to, you'll have the recording of all of those pictures, but I am going to try and post them. What would I do? Just hook my phone to the computer and upload it to the module, right? I think I could do that with just a picture. Oh, yeah. Okay, well, one of you guys, that would be way better. We will take pictures of the ones that are here and put them on the group me so that you guys will have, so you guys will be able to see those too. So hopefully that's helpful to have you be able to draw it a little bit and see it in a different way. And then I think we're all done for the day. Do you guys have any questions from my online group? Any questions from my in the class group? Negatory captain. Good job, you guys. Thanks for coming here to do it. All right, you guys online, thanks for doing that and drawing on the whiteboard. I think that makes it a little more fun than just me telling you about it. So we'll be done for the day. Have a good day. All right, we'll see you guys. See you later. Thanks.